There's no silly question, so ask away. All right. So if you don't know who I am, my name is Thomas Kauffman. I am the guy on the red shirt right here with the Mickey Mouse. That's right. I love everything that has to do with animation. I find animation being just amazing. And, it's just impressive how people put pen and paper and make something out of it, right? Videos, movies, shows, etc. I mean, when I was a kid, I thought I was going to be an artist to an extent, and I sketch every once in a while. But nonetheless, a little bit more about me. I've been in practice as a chiropractor for 5 years now. So since 2019, I started as an associate. And 6 months in, I decided that I wanted to go in my own practice. So that's when I opened my first office. It was a different name, but now it goes by the Athlete Spot. And we just recently moved from St. Louis down to Nixon, Missouri, where we just restarted the process of opening a new office. So that has been exciting and kind of been a pain in the butt at the same time. But nonetheless, I love it. I've been an adjunct professor in various degrees, from graduate university at Logan University all the way to undergraduate programs like Maryville and Lindenwood University. I've taught myofascial courses, I've taught clinical methods, and I've also done the biomechanics and kinesiology courses at Maryville University and Lindenwood. So I have a passion for teaching. I like to teach easy stuff. I like to make the concepts seem easy and relatively applicable within the next couple of minutes, right? That's how I like to learn. That's how I prefer. That's how I think everybody should be able to teach. And at the same time, if you're helping people learn something, you're also cementing that you know this stuff. So back in 2021, I started Smart Care Education. And my goal with Smart Care Education is to provide the best dry needling courses for chiropractors, as well as the best rehabilitation courses in the sports medicine field for chiropractors as well. So today's agenda is we're going to be talking about what is dry needling, how it can benefit your patients, how it can benefit your practice, and how you can start implementing it in your practice at some point. Okay. So if you have any questions at any given time, let me know. Drop it in the chat, and then we'll get back to it at the end of the session. So what is dry needling? And one of the first questions that we typically get is dry needling the same thing as acupuncture? And the answer in short is no, right? The only thing that these two techniques share is the filiform needle. And that is the tool that we use in dry needling and the tool that they use in acupuncture. And it is right here on the right side of the screen, right? It's a very, very thin needle. It ranges anywhere from gauges of 20 millimeters all the way up to 35, and lengths of 5 millimeters all the way to 125 millimeters. I've actually had to use some 125 millimeter needles in some patients. It's pretty awesome, but pretty impressive as well, the depth that we can get with dry needling. So dry needling is a skilled intervention that utilizes this filiform needle to stimulate myofascial trigger points. And these are hypersensitive areas of muscle and connective tissue that typically produce some type of pain referral to your patients. Now, a lot of times, chiropractors utilize other techniques like ART, pin and stretch, cupping, Graston, etc. But I haven't found anything that delivers the amount of relief to patients like dry needling has. So we talk about the myofascial trigger point, and in our courses, we really dive into the different models of the hypotheses of why trigger points occur. So I'm not going to bore you guys too much with that. But when we're talking about dry needling in comparison to acupuncture, dry needling, all the effects that we are seeing in the patient can be explained through a neurophysiological and biochemical context. So we're not talking about the meridians. We're not talking about the day of time that the pain comes around. We're not talking about the energy systems, right? We're not trying to correct any type of energy within the system. We are looking at the muscle, the connective tissue that we have in front of us, and if it is hypersensitive and we have a trigger point in the muscle, we are going to utilize the needle in order to provide relief to our patients. Now, we don't just go in and stick needles wherever, right? We do our assessment, and a lot of it comes from maintaining proper communication with your patients and getting their pain patterns, right? So these are your referral pain patterns that muscles can create. Do they have any faulty movement patterns, right? This is also going to be integrated with your posture assessment. So you're going to start seeing, or we start seeing, how patients move, how they walk into your office, if they're antalgic, if they're leaning towards one side, or if they're just walking normal and they just have a lot of pain. And then palpation. Palpation is probably the biggest thing. And as chiropractors, that is our bread and butter, right? We are palpating the spine all day, every day with patients, with our colleagues, with our friends. We are really making our hands and our fingers our main tool, right? So developing your palpation skills not only helps you, one, identify the segments that you're going to be adjusting, but it's also going to help you identify hypertonic tissue, hypotonic tissue, spasmic tissue, right? There's different levels of hypertonicity that lead to a spasm. So palpation is also going to be very important with your assessment, as well as your neurological and orthopedic examinations. These we can't really, forget about them. Now, we talked about two dry needling models. Those are the models by Dr. Travel and Simons, which is mostly the trigger point model based on sarcomeres. And then we also talk about Dr. Gunn's approach, the radiculopathy model, which looks at trigger points coming from a neuropathy standpoint. So in the courses that we teach, we take these two models and we dissect them in quite an extensive manner. And then we see where the holes are and we start to make those connections between one another, right? Because who's to say that Dr. Travel and Simons are not 100% right, but Dr. Gunn is also not 100% wrong, right? And it is not always clear where the trigger point really came from. Could have been from an overuse injury, could have been from a nerve that got irritated and all of a sudden all of the muscles got spasmed out, and now you have a trigger point, right? So what do we do in these type of cases? Well, we needle, right? We needle the myofascial trigger point. And one of the reasons why we needle the myofascial trigger points is because I have seen it in practice over the last 5 years. And, Dr. Quinn beats me by so many years. But I've seen it in my office where patients come in and they fail PT, they failed muscle relaxants, they failed prescription medication for muscle relaxation, they failed other chiropractic treatments, they failed soft tissue, and they still have this pain. And the problem with muscle pain is it is often undertreated and often over-medicated by the medical profession, right? So when these patients come into your office, what are you going to do different? And one thing that we found is needling really has helped these patients muscle pain. And it not only reduces it by 1 or 2 levels, it reduces it almost in half within the first session. I'll share with you some of my extreme cases that, I don't really think a lot of people are going to see them, but honestly, they come in quite often to the office, right? So with the myofascial trigger point and dry needling, the goal is really to desensitize and inactivate these tissues or these areas, right? And provide relief to our patients. Now, how do we do this? Well, needling itself is a pain control mechanism. And in the courses, we really dive into what is going on there in the neurology, right? So anywhere from the stimulation of those small alpha delta fibers that go up all the way into the central nervous system and create a cascade of effects that just releases a lot of feel good chemicals, right, for our patients. But not also are we doing that. We're also stimulating the tension of the muscle. When we introduce the needle in the system, when we are in the right muscle, in the right tissue, what we're going to do is we're going to cause a local twitch response, which is taking the muscle past its threshold, forcing it to contract, And as a means, it has to relax, right? So here we start seeing that with needling, we can reduce muscle tension, normalize the biomechanical and electrical dysfunctions of muscles. And with that, now we have less pain, we have improved muscle function for the time that they're in your visit. Now you can take them into an active rehabilitation approach where you can start doing DNS, when you can start doing McKenzie, where you can start loading them with a kettlebell. Heck, if you want, put them on a squat bar and start making them squatting with some weight, right? It's always going to be dependent on where your patient is in their path as your patient, right? So when we needle, right, we're not just poking tissue. There is always a reason why we needle, and we really cover the how to needle, why we needle, and why not needle a patient in our courses. Now, of course, we are going to needle a lot of our patients. That's part of having a new tool. You're probably going to needle a lot of your new patients when you get certified. That's totally fine. As you develop your clinical acumen and you develop your clinical reasoning, you will start to see that some patients benefit from needling more so than others. And we call these respondents and non-respondents, right? Some are going to respond amazingly to the stimulation of mechanical tissue, and the trigger point is going to go away, but the pain may not go away, right? Some of them may respond to the pain management, but the trigger point may not be completely taken care of because they just go home and do the same thing that they've been doing for the last 25 years. They don't change their lifestyle, they don't change their daily habits. So you can start seeing how, sometimes patients are going to get needling for one reason, and sometimes they're going to get dry needling for another reason. Now, in the courses, we really try to get as in-depth as we possibly can. And the two main needling sessions that we teach in the course is superficial needling session and a deep needling session. So with the needle, are you in the muscle? And we really can't teach it online because you have to feel it yourself. You have to feel the differences in connective tissue or between connective tissue, fatty tissue, and muscular tissue. But once we have the needle in, there are a cascade of effects that are going to be happening within the system, all the way from stimulation of neurophysiological changes, chemical responses, an inflammatory response because the needle is in the patient. So we start seeing a ton of local inflammatory changes that are going to help improve pain perception. We're going to see a lot of mechanical changes that are going to improve that muscle tone and are going to help your patients move from a painful situation to a non-painful situation, then into an active rehabilitation state, right? Now, when we're talking about chiropractic and dry needling, right? I mean, I love to adjust my patients. I adjust pretty much all of my patients. About 80% of my patients get dry needling care, and the other 20, they either are afraid of needles, they've had it done before, they don't like it, or they have a condition where if I were to insert a needle, there's probably something going to happen, right? So like diabetes, or they're on blood thinners. So those are some kind of red flag scenarios where we say, okay, we're not going to needle. We can do other soft tissues. We can do other stuff for you. But we focus on needling to really work on those myofascial trigger points. And one of the reasons is because I have not adjusted a neck that does not have some suboccipital involvement, that does not have some cervical spine, paraspinal involvement, some trapezius involvement, some SCM involvement, right? So for every somatic dysfunction of the cervical spine, you're also going to have muscles that are going to have trigger points. Now, these could create a pain referral that looks like a headache, could really create headaches themselves, could be the reason for the neck pain, right? Could be the reason for the low back pain, shoulder pain, and pretty much a lot of different pains. Now, not only can myofascial trigger points be the cause of some of these dysfunctions, they can also complicate things. If you have somebody that just got injured and they're just, they're coming back and there's 2 weeks after their injury, they're already coming with reduced joint range of motion, right? So this could be because they actually injured their joint, or they have trigger points in some of the muscles, and it's not allowing them to really take that joint through its full range of motion. Now, trigger points can also increase pain sensitivity. We call this allodynia, right? And we grade it in 1 and 2. So I've had patients that come in here. Actually, I'll tell you a quick story. I wasn't going to share this one, but when I was in St. Louis, I had a runner that came in with a meniscus injury, and we wanted to really take the meniscus injury and rehabilitate it properly. So we started working on his quads, and I applied the lightest pressure on his left quadricep, which was the leg that had the meniscus injury. And my patient went from a supine position, relaxed position, to fully seated with his right arm cocked up like he was going to punch me. I just looked at him and I said, "Did that hurt?" He's like, "I guess so, because this has never happened to me." We both kind of laughed, right? But uh, these trigger points can really increase the pain sensitivity for your patients. So working on them, right, with ART, pin and stretch, might be more aggravating for the patient itself rather than just sticking a couple of needles, getting rid of the trigger point or influencing the muscle to improve, and then help him out. So basically, our treatment for him was we needled his vastus lateralis and vastus intermedius. We did 3-4 sessions with that. At the same time, we had different exercises that he was doing in the office, and lo and behold, he improved. Right now, myofascial trigger points can also cause negative neuroplastic changes. Right, these are the compensations that your patients are going to come in 3 years later, 4 years later. They're going to be walking a little crooked. They're probably not swinging their legs appropriately through their gait. If it's a hip pain or knee pain, even low back pain, they can also avoid certain movements and they can walk differently, right? And when you assess them, they have full range of motion. They're able to go through the process. Their orthopedic examinations almost come back negative. So this is really telling you that there are myofascial trigger points within the system that have changed how your patient really moves. And in these cases and scenarios, we utilize dry needling to rehabilitate the muscle from a deeper center, right? So stimulating the central nervous system, making those changes, and then taking them and loading them in a rehabilitation setting. So this is a non-extensive list of some of the most common conditions that I've treated in the last 5 years with dry needling, right? So knee osteoarthritis, hip osteoarthritis, piriformis syndrome, pretty much have treated a variety of patients here. Carpal tunnel syndrome, migraines. We haven't had the best solution or the best effect with migraines, but when it comes to tension type headaches, sinus headaches, as well as cervicogenic headaches, dry needling has cleared those headaches almost within the hour for most of them. Now, temporomandibular dysfunction, we treated a lot in St. Louis. I haven't treated many here in Nixa, but I've only been here for 6 months. I just haven't really met a lot of dentists in the area. Shoulder, neck, and low back pain, pretty much we needle these conditions quite often, right? Plantar fasciitis, we've needled some of that. Tendinopathies and scar tissue, these we needle in a lot of power lifters, weightlifters, and CrossFit athletes. Tendinopathies usually tend to respond really well to the hypoalgesic effect of needling, and scar tissue, especially scars like C-sections or appendectomies that used to happen, and they had 2-3 inches of scar tissue. We needle these scars, and patients really report a lot of reduction in pain. I just had a patient. She's in her 40s, and she's had 3 kids, and we started doing some low back rehabilitation for her. And 2 weeks into her rehab, she mentioned that she had, during her hip hinge, her C-section was hurting, which kind of threw me off a little bit, but we did our assessment. Scar tissue wasn't moving properly. The scar wasn't really moving, and we needled it. 2 needling sessions later, she had no more pain. So, we worked with scar tissue quite a bit. And then obviously muscle strains related to some sporting activities and other related injuries. Now, there are 3 main physiologic effects that occur with dry needling. You're going to have your mechanical effect, your neurophysiological effect, and your chemical effect. Now, we've already talked about the mechanical. That is when we insert the needle into the muscle, and if it is a muscular trigger point, you're going to get a local twitch response. And this is also one of the big differences between dry needling and acupuncture. When we work with dry needling, we are looking to elicit a local twitch response because we are needling into muscle, right? Acupuncture does not look for that. It does not even care much for that local twitch response. The neurophysiological effect, this is the hypoalgesic effect of the needle. And this was first talked about by Dr. Carl Levitt in 1979. This is where we started to notice that introduction of needles within the system caused a hypoalgesic effect. Now, if you add the needle and a local twitch response, the patients tend to improve or tend to have results faster, and their results tend to last longer than if you were just sticking the needle in whatever tissue, right? And then obviously the chemical effects of being needled, right? So we have an inflammatory response that is going to create a cascade of chemicals that are going to clean up other chemicals that usually surround myofascial trigger points, like substance P, right? This is usually seen when you localize a trigger point and you treat that trigger point, you get rid of substance P almost immediately. Patients tend to respond pretty quickly to those kind of scenarios. If you are not in a muscle, in a myofascial trigger point, and you're just in connective tissue, which can also be hypersensitive, then the hypoalgesic effects takes over, and that's when you start noticing that you can have a great effect in pain management with your patients, right? Now, I'm going to share an in-office case study. This was the first one that I was going to share with you, but I ended up sharing 2 others as well. This is a recent patient of mine. He's been with us for 3 months now. He's a 38-year-old male. He's had 9 years of chronic right low back pain. And when he came into my office, he is about 6'3", about 195 pounds, jacked. This guy is lean, right? He loves to ride motorcycles. He's into pottery making, and he works at trucking industry here, just about an hour from here. So he shows up and he tells me that his ride back has been killing him for like the last 9 years. For the last 3 years, it's been the worst it's ever been, and it just has stayed the same. He can't deadlift. He's a big power lifter kind of guy, so he loves lifting heavy, but he can't deadlift over 225 pounds. He can squat about 300 pounds, but he gets pain immediately after a couple of reps, and then the rest of the day, his right low back just kills him. He can't ride his motorcycle because going over bumps just aggravates his right low back. And then pottery making is a no-no for him because of the position that he's in. He's a bit tall. He's a bit tall of a guy. So, hunched over creating pottery is probably not the best position for him. But, can't always change the environment of your patients. So, palliative, well, he does know, lacrosse ball smashing, so he does that every once in a while. He gets about 20 minutes of relief, and that's pretty much it. He's tried chiropractic, he's tried physical therapy in the past, and he's gone, the opioid route with his doctors for some muscle relaxants, and nothing's helped. He was currently getting adjusted by the chiropractor at his job. They actually have a chiropractor on staff. So he was getting adjusted pretty much every week, and he had just general low back stretches, right? So we chatted, we started our assessment. We did our full evaluation, dermatomes, myotomes of the lower extremity. They all came within normal limits. Ranges of motions were pretty even. He did have more discomfort when he was laterally flexing in the lumbar spine to the left and when he was rotating to the left as well, right? During palpation, we found a hypertonic right quadratus lumborum and hypertonic lumbar paraspinals. Those were just aggravated at the same time. When we did a deep palpation of the right QL, we reproduced the jump sign, which is when your patient literally almost jumps off the table, right? So at that point, I had an idea that the right quadratus lumborum was involved. We did a genitourinary exam, questionnaire, not an exam, just a questionnaire. He passed. It was all within normal limits, so no kidney infection, nothing internal that we had to worry about. So there were no red flags in his case. And so we decided to go ahead with the treatment. We did a dry needling treatment to the quadratus lumborum. We had 3 needles to the right quadratus lumborum. They stayed in the patient for 8 minutes. There was no additional stimulation. He was pretty aggravated. So we decided that we were not going to twirl the needle. We were not going to add electrical stimulation to the needle. We were just going to insert those needles and be done with it. After the 8 minutes, we introduced him to the DNS bear position with alternating leg lifts. He did 5 in the office with the right leg and 5 with the left leg. And then that was his homework. He was to do the DNS bear position for the next couple of days until we saw him again before working out. He called me the next day around 4:30 in the afternoon when he got off work, and he said that he had 0 pain in his low back since he woke up. And that was a weird feeling for him. And I laughed and I said, I hope this lasts. You never know, right? So I hope this lasts. I'm glad that you're feeling great. Let me know if anything changes. 3 days later, he came back to the office for his follow-up appointment. Same thing. He reported 0 pain, and he reported 0 pain since his first treatment. And he actually, that morning or that day, he had gone and worked out and he had deadlifted 400 pounds without any pain. And I scolded him a little bit because we had agreed that if he was feeling better, he was not to deadlift more than 300 pounds, but patience, right? Patience. So nonetheless, he has been a patient here for 3 months. I see him every 2 weeks, and he comes in for just general care every once in a while. As a matter of fact, he texts me. He's supposed to come in this week, but he texts me that he's feeling so great, so good, that he wants to bring his wife in. And I was like, perfect. Love it. Let's do it. Right? So you get this kind of reaction from your patients, right? And he is not somebody that would have chosen dry needling if somebody had just told him, we're going to needle you because of this, right? This was a conversation that we had in the office. What are the benefits of dry needling? Pain reduction, improved muscle function is going to help us get you where you want to be in the long run. And I am not the only one that says this, right? I love dry needling, but the research is out there as well, right? Dry needling is effective when combined with other therapies, right? So Cesar de las Peñas, right here, they did a research article. They looked at a meta-analysis of dry needling. We do have really good low to moderate evidence suggesting a positive effect to combinations of dry needling with other interventions. And we talk about these effects in our course, right? What are the short-term effects of dry needling? What are the long-term effects of dry needling? Another one, right? Upper trapezius pain threshold. After 10 minutes, right? After 10 minutes of dry needling, the upper trapezius and there was an increase in pain pressure threshold for local pain of the myofascial trigger point over the upper trapezius muscle and the distance pain-free regions, right? This was compared to myofascial release scraping and then to sham treatment, which was done nothing. So overall, the effect of dry needling was stronger than and superior to that of myofascial release, which showed a similar response as a sham treatment in pressure pain threshold levels at pain-free regions. So we start seeing the effects are there. We know the effects are real. Our patients are going to benefit from it. We see them quite often. So what do we do in practice, right? How can you start doing this in practice, or what does this look like in practice? Well, in practice, the treatment can be a standalone procedure, or it can be an adjunct procedure, right? You can choose to do dry needling sessions on your own, or you can adjust your patient, do dry needling, do some soft tissue, or you can dry needle your patient and do some do your adjustment. Now, I prefer doing my soft tissue first. I prefer doing my dry needling first. This helps me get rid of my fascial trigger points. This helps me reduce a lot of the pain perception of the patient. And that allows me to get a better adjustment from them. That allows me to put them in a better position for the adjustment before it's done, right? And we always do dry needling before we do any kind of rehabilitation programs. Now, when it comes to billing, there are two CPT codes. I'm not going to share them with you just now. One of the reasons is they're non-refundable, right? Insurance doesn't pay for dry needling just yet. However, it is a big win that we actually have CPT codes, and we do share them to those who take the classes, our course, right? And then obviously you have, since insurance doesn't reimburse you for it, everybody's doing cash for dry needling, right? So dry needling here is where your financial freedom can come, right? The most expensive treatment that I have ever seen was $135 for 30 minutes of dry needling in Colorado. And that was it, right? After that, the cheapest was $30, and that was as an adjunct procedure. I have a couple of colleagues in the St. Louis area and the Kansas City area that they charge for their adjustment, and then they charge $40 to $50 additional for dry needling treatments, right? So it can be financially lucrative from that standpoint. Now, if you're curious about dry needling, where can chiropractors practice dry needling? Well, as of July 2024, states here in the green, these are all the states that allow chiropractic to needle, right? And this is not just acupuncture needle. This is specific to dry needling. So Alaska, Arkansas, Colorado, Florida. Florida just so happened to do this in February. So that's a big win for Florida. Missouri just so happened to do this in June. So it's a big win for our state. This is thanks to the efforts of Dr. Quinn James, as well as the MCPA. So appreciate all that they do for the chiropractors here in Missouri. So if you are from anywhere else, make sure you join your state association. They really fight for you. So, big plug right here for them, even though it's not sponsored by anything. Anyway, Pennsylvania, this is, so every state here in the green allows chiropractors to dry needle. Pennsylvania is a little tricky. In order to get your chiropractic license, you don't have to have your PT boards, but if you want to dry needle, dry needling is considered a physiotherapy service, and you need your PT boards in order to have physical therapist privileges as a chiropractor. So that's the Pennsylvania loop around there. But make sure, always call your state board and make sure that nothing has changed. Things change a little slowly, but you never know when they're going to change, especially with websites that don't necessarily are not necessarily super friendly for us. Now, in most of these states, the average education is 50 hours of education in dry needling in order for you to practice dry needling, right? So if you take a 27-hour course and you try to go to let's see, New Mexico, they're not going to let you dry needle because you don't have 50 hours. The same thing with North Dakota, Ohio, Oklahoma, North and South Carolina. If you take a 27-hour course and you go practice in Texas, perfectly fine. They only need 27 hours for you to start practicing dry needling. California, Michigan, Nevada, Mississippi, Hawaii, Georgia, Oregon, and Washington do not allow chiropractors to needle at all. You cannot even get an acupuncture license as a chiropractor. You would have to go to acupuncture school and then become a licensed acupuncturist in order to needle, right? So now, not only is the United States the only one doing dry needling, you have countries like Australia, Belgium, Canada, Norway, Chile, Canada, I said Canada twice, Spain, and other places that are doing it, right? Now, if you want to become a dry needling practitioner, we do have a registration open October for the October-November cohort. These are 2 pre-scheduled weekend trainings. The cohort is limited to 16 students, and you get a lifetime certification. Not only do you get a lifetime certification, you also have lifetime access to needling videos, updated course materials, case studies, as well as other treatment videos that we post on, that we're going to be posting on the miscellaneous part of that. Now, if you're not ready for a dry needling course and you are waiting until 2025, we have some course dates coming. We're going to be in Kansas City, St. Louis, Dallas. We haven't figured out where in South Carolina or Maryland we're going to be, but we are bringing seminars to these cities and these states. All right. Good night. Have a good one. Adios.